Wonderful video presentation. Thank you so much to all of the students and VODAN-Africa participants who created that. And I'd like just to pause for a moment, and if Dr. Van Reisen is anywhere near the podium, ask her if she'd like to summarize what we've heard so far and why is this important?
Well, thank you, Christine. I think that it was actually very clear from the video, but maybe just to reiterate that what the key proposition is that is now going to be deployed in these 88 facilities is that the data is entered as it would have been entered actually under any normal situation. But in the normal situation, the data would go away to Norway or to the US and would never remain or even come back in the health facility. But because this data is, with this competence that Aliyah was talking about, is stewarded as machine actionable, it then can serve with one entry multiple purposes at the same time. And this is really a very simple first iteration that we that we have now developed as a minimal viable product. But even in this simple structure, we are already having a reuse of the data in 4 different streams. And one is with the data being retained in the health facility, the statistics on a real-life basis being available on a dashboard in the facility, which is actually a huge difference if you see it from the paper-based locker rooms. The second is the aggregate data across, which is a big deal because we are doing this not only in 88 facilities, but also in 8 countries, which each have their own regulatory framework. And the only reason that we can do it is that we're using data visiting. Otherwise, this would just not be ethical or not be allowed. The third use case is that it still is automatically moved out into that health information system. You hear people speaking about DHIS2, that's one of the health information systems. Those differ from country to country. That is automatically generated from these templates that can differ from all of the facilities. So it is not that the templates are imposed on the facility. The templates are adapted to what the facility already uses or is required to use by the Health Bureau or the Ministry of Health. So that process of getting that data out in the health information system is automated and happens then automatically. And then the fourth use case that we are very excited about is the one where the machine actionable data are in this linked data store. We call it technically a triple store or an Allegro graph, and which is really going to allow us to do dynamic queries, which means that through these algorithms, we can visit this data with all kinds of questions, and that can be the basis really of a very interesting pipeline for AI. That one is going to particularly require work, a lot of work around federated statistics, etc., but also especially work around access and control. So this is something that really will need to be further developed, but we are incredibly excited that we have been able to develop these 4 use cases within this what we call virtual image that is now going to be deployed standard in all of these 88 facilities. Christine, I hope that this kind of was a short summary of what is now the proposition that we have approved for deployment in all of these facilities. Thank you, Christine. Back over to you.
Yes, thank you. Thank you. That was very helpful.